Hello everyone, welcome to our patient safety discussion. My name is Dr. Matthew Clark. I'm the chair of the Trainee Advisory Committee for the Royal College of Pathologists, and I'm a histopathology trainee and a PhD student.
I'm Hamid Turf. I'm a trainee in medical microbiology and infectious disease, and I'm also the vice chair of the Trainee Advisory Committee.
I'm Laura Whitehouse, and I am an oral and maxillofacial pathology trainee. I'm also a PhD student, and I'm the oral and maxillofacial pathology trainee representative for the Royal College of Pathologists.
And the reason we're taking part in this discussion today for Patient Safety Awareness Week is that errors and mistakes will happen to all of us in our careers at some point along the journey. No one sets out for a mistake to happen. It's just part of human nature, and unfortunately they do happen. But the important thing is that we need to improve the culture that exists currently and make people talk about these errors and mistakes and be honest about them so that we can actually learn from these experiences. And so having little group discussions like this and deriving learning points from different examples of where mistakes have happened can ensure that we can publicise this information to other trainees across the network so that everybody can be aware of these potential problems and prevent them happening in their own departments. And so what we're going to do today is discuss different scenarios of the different errors and mistakes that can happen in pathology, what actually happened, the outcome for the patients and the departments, and the learning objectives that have been derived from those. And the first one we're going to talk about today is one centred around histopathology, and probably one that actually most of us in histopathology have come across in our careers. It centres around a consultant and a trainee who were reviewing a biopsy specimen down the microscope. And the trainee was asked for their view about this, and they noticed that there were some dysplastic and malignant cells in close opposition to the main part of the specimen, and so thought that this appeared to be an adenocarcinoma. But actually then the consultant was very suspicious about this and wasn't convinced that actually the malignant and dysplastic cells were part of this original biopsy. So decided to do some immunohistochemistry, some different stains to try and check where these cells were specific to the biopsy specimen, and found that in fact they were different, and so therefore what we call carryover, and had been derived from another specimen. Looking back then through the records, so they could see that going back to the cut-up bench where the specimen had been processed and trimmed, the previous case to this had in fact been a specimen that was expected to be an adenocarcinoma. So the consultant's suspicions were proved to be correct, and in fact the original biopsy was completely benign. So I think we can appreciate in this circumstance, if that hadn't have been picked up, that patient who actually had a benign specimen may have ended up being told they had a malignancy, a cancer, and then may have actually undergone surgery to actually have something removed, and all the morbidities associated potentially with that. So this was actually prevented from actually happening. So first of all, perhaps we can discuss how do we think this actually happened in the first place? Does anybody have any thoughts about that?
It happens so commonly. The most obvious thing in this case, it seems to have come from potentially the cut-up bench, where the case before was an adenocarcinoma, and we tend to use the same knives and the same bench and everything for every sort of specimen that comes through in a particular cut-up time slot. So it can happen very easily if you don't clean your knife in between, if you don't clean the bench down in between. Those things can be carried over onto the sections that you've taken, which are then going to be embedded and processed.
Absolutely, and certainly from my experience as well, this can happen quite often. I think probably every histopathology trainee has had some experience of this, but often the carryover is perhaps at a distant site to the main part of the section. It's one of the things you're always taught, certainly in histopathology, when you're reviewing a slide, is to look at the whole slide to pick up potential problems like this. But in cases like we've just discussed, where the two pieces of tissue are actually right next to each other, that's when it's less obvious to actually pick up. And I guess through experience, that's what's going to be important. Are there any other potential parts along the process of from the specimen coming into the department where carryover could occur?
Potentially in the actual processing, because again, the same machinery, the same water baths, everything is sort of used the same for all the specimens that are done during a given time period. So when things are embedded in the lab by the biomedical scientists, similar sort of things can happen where you get bits of one specimen embedded in with bits of another. These things do happen.
Absolutely. I suppose thinking about prevention, cleaning of these things frequently is going to be an important part of it. From your experience, Hamid, of microbiology, do you have similar problems of sort of carryover happening at all, or any sort of similar instances?
Well, not carryover as such, but we do have cross-contamination, for example, from samples. So similarly, if you're processing a sample and then move on to the other one without cleaning the bench, then you can get cross-contamination into this next sample.
Right.
Or even from the environment. Sometimes if you have a window opened, you can get like an aspergillus floating on the plate.
Okay.
Or even sometimes even from the like the ventilation, if you've got a ventilation a unit just above the bench where you're working, you can get contamination from that if it gets colonized.
Okay.
So it's it does happen.
Right.
And it obviously triggers a process of trying to figure out whether this is if this organism is actually a clinical pathogen, or is it an environmental contaminant, and obviously it just not the best situation really.
I suppose that clinical context is going to be quite important with that, because I suppose aspergillus could actually be what the patient has. So you've got to have your wits about you, I suppose, to make sure that you're not calling something a contaminant when in fact it is actually what you're looking for.
You can also look on the plate sometimes and you see where you've streaked the sample and whether this falls on the streaking line or not. If it doesn't, it just kind of confirms your suspicions. But obviously, it needs quite high element of suspicion when dealing with these issues.
And I suppose as well, it goes right the way back to the very beginning of when the sample was actually taken. So potentially the doctor or the nursing staff who were actually taking the culture, that could have been the point where contamination could have occurred as well. So it may not have even necessarily been in the lab, but actually even at the point of where the sample was derived.
And even with the samples that we ask patients to take themselves, like urine samples, you often get contamination. And if you rightly said, blood cultures, if you don't kind of decontaminate the skin well before you've actually take the sample, you can get contamination with skin organisms and so on. So it could be also at the source rather than in the lab.
So going back to our sort of scenario that we have here with this carryover, if we think about what exists, are there sort of protocols in your experience, Laura, for at the cut-up bench, or SOPs for trying to prevent this at all, or does that exist at the moment? Or
generally, you are supposed to clean down everything in between each case. So you're supposed to clean down your bench, you're supposed to clean down your knives and things like that. Some people, in my experience, have used tissues almost to just cut up your samples on, which then prevents that. It also makes it easier if you then need to go back to the sample later, because you can wrap it up in the tissue and put it back in the pot. So there are some people who do that, but sometimes that's not very easy to do because you can start cutting into tissue. So
bits of the tissue then
can get into it and things like that. So there isn't really a very specific and sort of one answer fits all with this. It's going to be very lab dependent, I think.
Do you think the sort of work environment as well makes a difference to this? And certainly from my experience with cut-up I've done, you have your sort of half an hour slot and you're presented with a trolley that's stacked up to the brim with lots of pots. So there's certainly a pressure of time and getting through things quickly. So do you think that's a factor in workload, and the environment that you're working in as well can be a factor? I
definitely do. I think that's a real thing, because we all have turnaround times that we're supposed to meet, and the limiting factor sometimes with that is cut-up time, because if you're not cutting up the cases, they're not getting processed, and then that limits the amount of time that you have to look at the cases, to make a diagnosis, order extra tests if necessary, which then puts a delay in terms of the patient getting their diagnosis, which is again another patient safety issue. So realistically, yes, I think that is certainly a factor sometimes, is that if you have a lot of cases that you want to get through, that it can be an issue.
So I guess, yes, there's sort of workforce issues if you've got pressure on your shoulders. I think one of the things I've often found in labs as well, there's so many distractions and things as well, that phones going off, other conversations, people doing other things nearby to you. There's a lot of things potentially to distract you from what you're doing, and you can very easily see someone forgetting to wipe the knife or wipe the board down in between a case if someone's then tapped you on the shoulder and said, oh, do you remember this case, etc. So I think those things, if they could be minimised, that could make a difference. So if we sort of think about perhaps the learning points from this scenario, what do you think are the main things that we can take away from this?
I think one of the big things for me as a trainee is to have a high level of suspicion. When you look at cases like this, and you need to have a high level of suspicion with regards to what you're looking at. So that's one of the main things that I've taken away from this, and that experience means a lot.
Absolutely, and I think one of the things it's actually having the ability to say these things, so having a suspicion and then acting on it, because it would have been very easy for this to just be reported and you could, that's what's so frightening about this example, is how easily you could say, well, if you could just take it as, yes, this adenocarcinoma could happen in this tissue as well, that's what it is. But it's again...
It actually meant that the presence of someone senior supervising you during your period of training is quite crucial, because then you've got that experience, which it's difficult as a trainee to have the same experience as a consultant who've been doing this for years.
Absolutely.
And I've seen all different sorts of issues and problems. So it's it shows how important it is to be supervised, and that's what we should be, so we can learn and learn the right thing.
And that experience in the consultant in this case is the barrier or defence in this situation, because it was their recognition of that stopped it going any further. And you'd hope, again, you mentioned about the training, that we're certainly in departments I've worked in, we have a sort of black box section where interesting cases go into that and then are reviewed by all the trainees. So it would be hoped that in a situation like this that would happen there as well. Do we think there are any ways that, I mean, this is a carryover, has always been a problem. It sounds like it's a problem for most specialties in pathology. Is there any way we could prevent this in the future at all?
Other than having specific SOPs and ensuring that people comply with them, potentially longer cut-up periods with fewer cases. Also some sort of mats or something so that you can change.
I suppose a sort of a disposable, something that could be done for each case, but again, logistically, it would need to be worked out whether that's possible or not. But perhaps the simple things like the work environment, minimising those distractions, perhaps having a more quieter section of the lab to do these in, and like you say, the less of the time pressure, particularly make it a much more manageable situation could be done as well. But yes, so those things could be done to help it. Thank you.